All right. Good morning, everyone, and welcome to Grand Rounds at Sutter Santa Rosa Regional Hospital and Santa Rosa Family Medicine Residency. It is nice to be with you on this hot Wednesday morning. Before I pass the torch over to Dr. Mase and Dr. Shende, I just want to take one moment to recognize the terrible tragedy that happened yesterday in Uvalde, Texas at Robb Elementary School, and to recognize our role in advocacy around public health and public health safety around gun control. There's so much we could say about that, but I couldn't let the morning start without at least taking a moment to think about those families and our nation. And all right, after a deep breath, I am going to pass the torch over to Dr. Shende and Dr. Sundari Mase. I am sure that you all know who both are, perhaps the most celebrity physicians in the county of Sonoma for the last couple of years. Dr. Sundari Mase, of course, our Sonoma County Health Officer, and Dr. Urmi Shende, the Sonoma County Vaccine Chief. We're so happy to have you here today talking about the topic that we've been talking about for years, COVID and the pandemic. So thank you for coming. Thank you for speaking with us today, and the floor is yours. A reminder to anyone, if they have questions or comments, you can use the chat box, or you can text me on my cell phone. The number will be there in the chat box. So welcome, Dr. Shende. Welcome, Dr. Mase. Thank you.
Great, thank you so much. Dr. Shende and I are going to kind of tag team this because, as you said, we've both been immersed in the COVID-19 pandemic over the past 2 years. And I have to say that we would have never achieved the successes that we've had without our vaccine chief, Dr. Shende, because she's been instrumental. It's not a job that one person or anybody or any particular team could do. We've had so many collaborators. Every one of you, I'm sure, has contributed as well. So thank you for having us this morning. The title, Pandemic Pearls and Pivots, is quite apt. We've learned a lot over the course of this pandemic about COVID-19 and how to actually respond to a new threat. And Veronica, I really appreciate your words about the tragedy from yesterday. We actually were just discussing that last night, and I'm at a meeting actually for tuberculosis, but it was a topic that was discussed and how we just need to address these public health threats, and that's definitely a public health threat as well. So let me see if I can advance my screen. Perfect. So as you know, the COVID-19 pandemic has had huge impacts globally and nationally in our state as well as in our county. COVID-19 has caused a reported 6.28 million deaths worldwide. And that's probably an underestimate because we know that there was a lot of unreported cases during the course of the last 2 years. In India alone, I think there's some estimates that the death toll is much higher just based on looking at data from prior years and comparing to data from the last 2 years. But we may never know exactly what that death toll is worldwide. In the US, we've been one of the hardest hit countries, as all of you know. The number of people dying from COVID-19 has now surpassed 1 million. And more people have died from COVID-19 than from AIDS or from the 1819 influenza pandemic, which was the last pandemic that the world faced. The US has observed the largest drop in life expectancy since World War II. And there have been, as you know, hard hit sectors, disproportionate numbers of deaths among people of color, and that we've seen that here in Sonoma County. There's been a stark difference in who's been impacted and to what extent in terms of case rate, hospitalization, death, and life expectancy. And we're going to go into that. So over the course of the next 40 minutes or so, or I guess we want to do Q&A, so maybe 25 minutes, we're really going to focus on how COVID-19 has impacted Sonoma County and how public health and the community have responded to this pandemic to make sure that we prevent the worst outcomes, infection, but also to promote equity, preserve lives. And you can see here that there have been 1 million deaths in the US, 83 million cases. We've had 8 million cases in California alone, close to 9 million actually, and 90,000 deaths. And in Sonoma County, we're close to 90,000 cases, and we've had 491 deaths. And we'll go into what rate we have in terms compared to other counties here shortly. So the toll has been great. And this slide just kind of depicts what we've faced the last 2 years. Now, here in Sonoma County, we jumped into this and realized that we needed surveillance was one of our key tools, and access to testing. As you know, we've had issues with that throughout the pandemic, especially at times when we've had surges. And we are so lucky that we have a regional public health laboratory here in Sonoma County. Not every county has their own laboratory. And not only do we have our lab with Dr. Rachel Reese leading it, but we also have a regional lab. And we were immediately set up PCR testing in our lab. And Rachel and her team, Dr. Reese, that is, have spent so much time and effort to ensure that we have a good, several different testing platforms, and that our turnaround times have been excellent. In fact, if you look throughout the pandemic, our turnaround times have been somewhere around 24 to 48 hours, and often under 24 hours. Early on, we were able to provide rapid testing through a gene expert kind of platform for people who really needed to know their status right away. In other words, healthcare workers, first responders, elderly that were very sick. We were able to prioritize rapid testing with results within a few hours through the gene expert system, which is a more of a nucleic acid amplification kind of a test. But you see, we've processed over 216,000 of the total over 1.5 million, 1.6 million PCR tests conducted to date. And as you know, now we have antigen we've had antigen testing for well over 1.5 years, and people have been shifting more and more towards antigen testing over the course of the pandemic. We also have serology that we've used, antibody testing to see if people have been infected with COVID. And we did early on implement antibody testing to try to get an idea of what percentage of the population was actually infected with COVID. And then genotyping, of course, to be able to detect different variants and be able to know what's happening in terms of the strains that people are getting in the county. And I just want to say that throughout this whole pandemic, partnerships have been so important. And we've had to, as we said in the title, pivot and change our strategies again and again and again, as we found more and more about the virus, how it presents, and how to respond. We've had the state of California has been front and center in leading the effort against COVID, providing platforms for testing, of course, with vaccine, and Dr. Shende is going to talk more about that. And of course, our FQHCs, and we have very strong leadership in our federally qualified health centers here in Sonoma County, and they have really taken the lead in providing services, especially testing and vaccination for the hardest hit communities that they serve. So without our partnerships, we wouldn't have achieved what we've achieved. And our focus has been on equity. We've had we're going to go into what our strategies were, but at all of our different testing sites, vaccination sites, we've had bilingual messaging. We have gone to the hardest hit neighborhoods and provided pop-up testing opportunities for people that don't have other options for testing, maybe do not have access to healthcare or the ability just to go buy a $20 antigen test. We've provided bilingual, bicultural testing and contact tracing staff to make sure that we're able to explain in the language that people speak and educate people about testing and vaccine and all the other non-pharmaceutical interventions that we have been promoting to prevent the spread of COVID. And then we've had gift card incentives to get people to test, to get people to get vaccine. And that's been really effective as well in achieving our goals. So again, as you know, we're now moving towards a phase where many people are doing antigen testing, and we're not necessarily able to have a denominator for who's testing and who's positive and who's negative. So we are beginning to pivot towards wastewater surveillance, which means we're simply going to go to the plants. We have several plants here in Sonoma County that, I'm not sure what happened there. Is that, I don't think I'm looking at my screen.
I don't know who Phil Sullivan is. Hold on. Okay, go ahead.
Okay, wait, do you see my screen? Are you seeing my screen or no?
No, you go ahead and reshare your screen, Dr. Mays.
Got it. Okay, great. So I was just talking about wastewater surveillance, which is an important way in which we can just get an idea of what the trends are in terms of COVID infection in the county by following over time how much COVID is being detected in the wastewater, as well as what variants. We can do genotyping and see what the predominant variants are in wastewater. And it gives us kind of a population-based way of looking to see what's happening to COVID-19 trends in the county. So just looking at this graph, as you know, we ramped up testing. With every surge, we've had a great demand for testing. In fact, this must have been the Omicron surge right here in the beginning of January in 2002, when we had a huge demand and were able to meet that need for testing. And even then, of course, we weren't able to meet the total need, but we were able to ramp up testing to levels we've never seen before in 2022. Dr. Shende, do you want to add anything about surveillance and testing?
Not about the testing.
Okay, great. So what have we been able to do in terms of our mitigation measures? So many different things that we have, as we learned more and more. As you know, initially, we had no idea how this virus was transmitted. Was it just through the respiratory route? Was it through fomites? In other words, you touch a surface and you get COVID from somebody else. And we really thought it was. And that's why we were talking about general hygiene measures and hand washing and hand sanitizer. And we were, cleaning surfaces and doorknobs and all that stuff initially. But we realized very quickly that this virus is transmitted through the respiratory route, and masking was going to be one of the most important things that we could do. And so we've had so many communication campaigns, outreach, press conferences. I think I was doing daily press conferences at one point just to put these messages out. And Sonoma County was the first county in the Bay Area, at least, if not one of the first counties, first few counties California-wide that had a masking mandate. And that, I think, made a big difference for us. And other counties basically followed suit right away. It looks like somebody's trying to be admitted. Should I admit them?
No, I got it.
Okay, good. All right. And then, of course, the hygiene, the social distancing that we did initially with the first variants of COVID was very effective. And then gathering size limitations. And we've had numerous times when we've limited the size of people who are together. The shelter in place was something that the Bay Area counties started for the entire country. And I believe it was March 18th or something like that. We put our shelter in place order into effect. And it was huge. It was a shutdown essentially. And people by and large abided by the shutdown. And as a result of the shelter in place, we averted a huge disaster of great proportions. The modeling, as you know, showed that in a short month or two after, by June of 2020, that we'd see a huge peak in cases and hospitalizations and deaths, overwhelming our hospital systems and just creating a pandemonium. And we averted that, but you often can't measure what it is you are able to avert. And so it became, obviously, why did we do the shelter in place became the big question, I believe, early on by people who didn't realize that we had averted a huge disaster. We had an alternate care site, non-congregate sites for our houseless individuals, people who are unstably housed. And the alternate care site did serve hundreds and hundreds of people, not thousands of people over the course of the pandemic. SSU is where we had our first alternate care site, and then we shifted from SSU in the dorms to hotel. And then, of course, we had local and state health orders to protect vulnerable populations. And we did have so many different orders that targeted the residential care facilities and skilled nursing facilities, other congregate settings like the jail, healthcare settings, all different healthcare settings, and schools. And as you know, schools went remote for quite a while because we didn't know what kind of transmission we were going to see, and we want to avert widespread transmission, especially to those who are in high risk settings and high risk. And also, we did target people in high risk other occupations as well. Fire, law, EMS is one that comes to mind here in Sonoma County. And then vaccines. And actually, Dr. Shende, you want to mention something about the vaccines and the whole effort?
You certainly can. And we'll get into a lot more detail as we go along. But I actually wanted to touch base about the first bullet point, the communication. I think one of the big challenges we faced was realizing that we had to reach so many different sectors of the population, so many subgroups. And it was very challenging. We encountered many impediments, as one can imagine. In the very beginning, the first rollout involved the elderly. So trying to overcome barriers of age, transportation, low tech, not very comfortable with tech services, language barriers, cultural barriers. There were so many. And yet it was imperative that we reached every sector of society as best as we could. So how did we pivot for that? As Dr. Mase mentioned, we did have many press briefings, sometimes on a weekly or even twice a week basis. The flyers that were put out over time, we refined it such that we were able to get weekly testing and vaccine flyers that were pretty accurate, not always 100%, but as good as we could get to get that information and messaging out. We did a lot of spot interviews on the radio. We did a lot of social media as well, something that many of us had not really done before. So posting on Nextdoor, of course, on Facebook, Instagram. We tried to get into TikTok, but it never really worked. But as many different mediums as we could. Some of us remember when there were only 3 television channels and 1 newspaper, and communication was a lot easier, but also was pretty limited. So trying to reach so many different parts of society was very challenging. In addition, of course, we were able to create quite a network, and the work that was done with community-based organizations, community health workers, promotoras was essential in being able to get that work out. And we'll talk more about that. And Cura, so many different groups that really made a difference. And in terms of vaccines, let's just continue on to the next slide because
I think we should, because we have a lot of slides and,
yes.
and limited time. So I'm going to speed up just a little bit here. We're just trying to give you the flavor of what we went through during this time. Now, of course, the disproportionate impacts of COVID have been felt throughout the pandemic, and Latinx residents, and here in Sonoma County, we have, I believe about 67% of the population is white, non-Hispanic, 23% Latinx, and then the other sort of 10% is everything else, basically American Indian, Alaska Native, Pacific Islander, Black communities, and then multiracial communities. And what we found is that the Latinx residents, being largely the essential workers and not being able to shelter in place when many others did, were the hardest hit in this pandemic. They've accounted for 45% of all cases in Sonoma County, while they're representing just 27% of the population. At one point, the case rate was, if you looked at per 100,000 population, was 9 times higher in the Latinx population compared to the white non-Hispanic. And in 2020, the life expectancy decreased by 2.1 years among Latinx residents compared to 0.7 years among white non-Hispanic residents. So the underlying disparities and health inequities that were already present just were magnified and brought to light during this pandemic. And relative to population size, all these groups that I've mentioned have experienced the highest rates of COVID-19 cases. And what we've done is really try to respond to that by focusing our efforts on these hardest hit populations. And if you look at age-adjusted hospitalization rates by race and ethnicity, again, Latinx persons have consistently had highest rates of hospitalizations with COVID-19 throughout this pandemic. And white non-Hispanic hospitalizations have trended up overall with higher rates during Delta and Omicron. But I just wanted to say that we saw more hospitalizations and deaths in the white non-Hispanic population, partly because those are the elderly folks in our county. So just on the basis of age alone, they were disproportionately infected because as you know, our skilled nursing facility residents and residential care facility residents were the ones that were hardest hit by the very negative impacts of COVID. But I think it's important that we see this and we are able to note that these disparities existed. Here's the age-adjusted rates by quarter in selected races and ethnicities, Latinx in the light color and white in the dark color. So it's something we've been tracking all along and trying to target. Addressing these inequities was the public health challenge of this pandemic. So many challenges, but this was one of the biggest challenges. We did form the Health Equity Work Group, has been incredibly important in guiding us throughout this pandemic, giving us strategies by which we can reach the hardest hit communities, ensure services are provided, whether it be education and outreach, testing, surveillance, vaccination, or any other of the services, for example, the financial assistance provided. And we've worked through our trusted messengers, our community-based organizations, the community health workers that were often bilingual, bicultural, promotoras who went door to door, going into the community, providing information, combating the misinformation that was everywhere, and providing resources. And Cura, of course, has been our very, very important partner in reaching the community, ensuring that financial assistance was provided. Our federally qualified health centers, other healthcare partners, the Sonoma County Office of Education, who we've had calls with weekly, sometimes more often, to ensure that our schools and our kids have had access to testing, surveillance, contact tracing, vaccination, et cetera. Rental assistance was given, and I don't know the exact total amount. I don't know, Dr. Shende, if you remember, but we've provided rental assistance to many, many people in need during this pandemic. And then we had ARPA funds and a community health worker grant. It was awarded $6 million over 3 years, that we're one of 35 counties in the United States that actually got selected for that grant. And that will continue to help us post-pandemic. Dr. Shende, you want to mention anything?
Yeah, a couple of things. So first off, I wanted to mention that one thing that hasn't been said yet is that Sonoma County never had a clinical arm. We used to many years ago. Some of us may remember working at the old county hospital back in the early 2000s. That was a while ago. So because of that, we didn't have any kind of a network of clinics through which we could expand and be able to provide the vaccine or provide testing. So the network that was developed with the federally qualified health centers is something that hadn't existed before. There hadn't been as much communication. It was very siloed. So being able to communicate, collaborate, and create that network allowed us to set up 13 different vaccine sites in a matter of about 6 to 8 weeks, which allowed us to be able to get that vaccine out into the community as quickly as we could to the prioritized populations. So that was key. And that collaboration with all the multi-county entities, meaning Sutter as well as Providence and Kaiser, was essential, along with the FQHCs, to be able to reach everybody. In addition, I wanted to mention that I don't know about the rental assistance specifically, but the EFA, the financial assistance that Cura was able to put out into the community, was in the range of 8 million, and the needs were greater than that even. So that made a huge difference in being able to support financially the communities that were hardest hit. And as mentioned, the trusted messengers we simply could not have done what we've done, and we could not have decreased the disparities without the hard work that they did. I remember one quick example. I just have to say, I was working in the clinic. I continue to work in the clinic 1 day a week. And I had a mother who told me that her nephew was a promotora. And he had been able to convince everybody in the family, from the 12-year-old cousin all the way up to the abuela, abuelo, and the entire family that had been completely resistant to vaccination. He was able to convince them one by one. Once that family was convinced, they spoke to another family, and they spoke to another family, and so on and so forth. So that kind of communication was extremely effective. And we hope that learning from that will allow us to continue to further health communication in the community going forward. But that was really quite pivotal. One other thing I wanted to mention is that a network was created, the COC, that uplifted the voices of a lot of these health workers. And I'd like to give a shout out to Dr. Fish, who's here, and Dr. Panalasi, and many others who really worked hard to uplift these voices, empower them, and again, made a huge difference in our efforts. Many other things I could say, but we should probably go on.
Yeah, and thank you so much for that, because we do have to, there are many of you who are on this call that have contributed so much. With ISOCare, Dr. Lossie, Dr. Fish as a huge support for public health during this time. And let me move forward here, because we still have quite a bit of information to present you. So trends in age of hospitalized patients over the pandemic is very interesting. While the 65 plus age group did account for the majority of hospitalizations throughout most of the pandemic, 50 to 64-year-olds had a similar age-specific hospitalization rate during Delta. Let me show you what these surges are. This was the initial surge. This was the December 2020, January 2021 surge. This was the Delta surge in the summer of 2021, and then the Omicron surge. And in this, the total hospitalizations are the sort of black line. The 65 plus age group, you can see here, is the kind of slightly kind of grayish line, and the blue is the 50 to 64-year-olds. So what we're saying is that during the Delta surge, we saw a lot of hospitalizations in 50 to 64-year-olds. And we knew that vaccine was extremely protective. Still, we had a huge number of hospitalizations, even in fully vaccinated individuals at that time. So here's the Delta wave and the Omicron wave. And I don't know, Dr. Shende, if you want to add anything to this. I do want to, we still have plenty of slides, but go ahead.
Yeah, let's keep going.
Yeah. And I want to focus on the deaths, because those are the most negative outcomes, obviously, that we've faced during this pandemic. Residents, as I'd mentioned before, 65 plus account for over 106,000 of our residents. In other words, we have 25% of Sonoma County residents are 65 plus. That sets us apart from many other counties throughout California and in the Bay Area. So we felt the need to really protect this population, because that was one of the specific things that set us aside here in Sonoma. The majority of the deaths, 75% of the close to 500 deaths, 491 deaths, have occurred among adults over age 65. And we looked at one point at over 75, and that population at that time accounted for 65% of the deaths. So we know that those are the people that we needed to focus on, and we did. We had huge outbreaks, as you know, in our skilled nursing and senior residential care facilities, especially before vaccination. So what we did was, as soon as vaccine was available, if you recall, prioritize that group for vaccinations, even through the system. And in fact, we had to change and pivot as soon as vaccination was available, canceling hundreds of appointments for vaccines to ensure that those slots went to people over 75 initially. And you know, you must recall those times when there was actually a lot of criticism for canceling appointments in people under that age group, but we felt that was important, and I think it made a big difference, because unvaccinated residents are nearly 14 times more likely than vaccinated residents to die from COVID-19. Dr. Shende was at the forefront of that. So do you want to say something about that process?
I think we all remember that very well. I think that a really important point to make is that if we hadn't done that, we realized that the appointments were booked out for 4 to 6 weeks. So it would have taken that long for somebody over the age of 75 who didn't have access to technology, who didn't have transportation, to be able to get in. And our mortality rate would have been much higher. As we'll see on the next slide, it was really dramatic what happened. But that move, I think, made a big difference in our mortality. I just wanted to give 2 quick sidebars. One, we had many elderly who were just in tears when they came to the vaccine clinics, realizing that their community actually cared about them and would wait and prioritize them over those who were younger. Second issue is we met somebody named Dr. Norman Panting at one of these events. He was a physician who actually started the first polio clinic in Sonoma County. Prior to that, he was placing patients in iron lungs right at the county campus on Shende. And within a year, he actually was the vaccine chief for the polio vaccine. And we know how that worked. So it was of historical significance to be meeting people like this. So if we want to go on to,
Yes.
yeah, go ahead.
Yeah, let's move on. We've already, I think, said this, but it's important to note that we also prioritize essential workers and marginalized communities, first and foremost. Ag and farm workers, food service workers, the unhoused, correctional facilities, school clinics. Let's not forget the homeless. We said unhoused. So we went to the shelters and provided testing, vaccination. As you know, we had one of the biggest homeless shelter outbreaks in the country with Sam Jones. And now we have a very high degree of vaccine coverage in the older adults. 93% of adults over 65 plus are fully vaccinated. And that has hugely impacted the decrease in deaths in our county. And I think it's important here to note that over time, that vaccination reduced COVID-19 deaths among residents of skilled nursing facilities and RCFEs. As you can see, look at initially cases are in the lower graph and deaths in the higher graph. Prior to vaccination, this population was so was hit very hard with the negative outcomes of death. And I remember at the time going into one of our large skilled nursing facilities and touring and seeing, the red zone, the yellow zone, the green zone, and just thinking, how are we going to protect these people? And prior to vaccination, we couldn't. We tried our best. We tried to isolate those who had COVID. We had the yellow zone for those who were exposed, but we would never know when someone in the yellow zone was going to become a COVID positive case and then transmit before they were detected to be a case. And the green zone was never really the green zone because we had cases arise in the green zone. So it was very, very challenging. But after vaccination, even though case rates with Omicron peaked in the skilled nursing facilities, look at the proportional deaths, so much less. In other words, we were able to protect people from the worst outcomes. I don't know, Dr. Shende, you want to mention anything else?
No, I think it just speaks for itself. And we know that we did see the deaths go up a bit when we had the variants, unfortunately, because they do evade some of the immune defenses, but still there's such a dramatic difference in the pre-vaccine versus post-vaccine era.
And here we are in pre-vaccine with dark green. This is deaths as a percentage of our total deaths in skilled nursing facilities, specifically in residential care facilities. And then during the winter surge, the Delta surge, and the Omicron surge. And you can see that even in the winter 2020-2021 surge, at the time when vaccine just became available, we still had a very high proportion of deaths as people were getting vaccinated. The vaccines, I believe it was about February of 2021 when we started to prioritize those over 65 for vaccine. And prior to that, you can see as a percentage of deaths, it was a huge percentage. And then with the Delta surge, it was much lower. With the Omicron, it was higher again, because as you know, with the new variant, the vaccine wasn't as protective at that time, and the booster helped hugely. Those people who got the first booster had much, much lower death rates. And we've shown that in graphs. I don't know if we have that slide here, but let me move on to show what the vaccine outcomes through the pandemic have been. So people who are unvaccinated are still about 3 times more likely to be infected with COVID, close to 20 times more likely to be hospitalized with COVID, and close to 14 times more likely to die of COVID. This is throughout, this is the past 90 days, and the death 14 times risk is since January 1st of 2021.
Only thing to add with that last one is all this information is on socoemergency.org. So if you have patients or people who still say, oh no, it's not making a difference, it's helpful to refer to this, because we hear about how many cases there are and how the vaccine's not working and there's still breakthrough cases. But this really helps to objectively see what the effect is of vaccination.
Well, I think that's a really important point. You know, now we're seeing huge case rates. We're up to 40, close to 45 new cases per day per 100,000, but we're not seeing the deaths, and the hospitalizations have gone up a little bit, but still, I think we've only had 2 reported deaths in the past month. And that's a big difference. So it begs to ask, you know, when are we going to stop necessarily focusing on just case rate and really look at the negative outcomes as COVID, you know, I guess we begin to learn to live with COVID. But I do want to note that our and let people know what our county progress has been in context. Sonoma County currently has the 9th highest vaccination rate of the 58 counties in California. Again, this is a tribute to all of our partners, all the healthcare institutions, whether you're the MCEs, the federally qualified health centers, solo practices, you know, all of the different vaccination sites that we've had over time, the community-based organizations, the health equity group, you know, every partner has been involved. You know, a shout out to Cheryl Fox and Associates and Curative, and you know, so many different partners have been involved in this vaccination and testing effort. So 78.7% is the total population that is vaccinated, not eligible. This would include our under 5-year-olds. And that's where we get the 78.7% number. However, if you look at eligible population, we're at 82% fully vaccinated, an additional 7% partially vaccinated, for a total of 89% with some vaccination status. And the boosters are catching up. I think we're over 65% total population with the first booster. And we haven't really tabulated the second booster because, again, we haven't been pushing that in the total population, just really, you know, those over 65. Although those over 50 are eligible for the second booster as well. Cumulative deaths in context, we've had 56.6% less deaths per 100K residents than California. And California has had far less deaths than the country as well. And the cumulative cases per 100K, we've had 22.9% less cases per 100,000 residents than California. And again, we're much better off in California than many other states in the US. Go ahead, Dr. Shende.
Just going to say, sometimes it's good to be the lowest of the low. I think our mortality rates are really commendable. One other thing I wanted to mention is primary care providers really bore the brunt, as well as hospitalists really worked hard. I know what it's like, that inbox, the constant headache, the constant questions, the constantly shifting guidelines. So I just really want to make sure that those who really did that work understand what a difference it made in our overall clinical outcomes. So thank you. So for this, we'd like to just go over the overall vaccine administration, where we are. As we can see, our numbers are pretty good. For the over 16, we're all now almost at 80%. And as we go higher in the age ranges, they are in the high 80s, and in the elderly, the most elderly, it's 94%. The group that is continuing to lag a little bit is the 12 to 15-year-olds. Even that has crept up quite a bit. We had been stuck at about 60%, but now we're close to 70%. We're hoping that we'll get that number higher. Our 5 to 11s, of course, are the most recently eligible, and we are 42% fully vaccinated and another 6% partially. The more we continue to encourage in this age group, the better, because as we know, it's a huge source of transmission, ongoing transmission in our community. I'd like to give some attention to the chart on the right and make a note of the fact that our Black population is 86% fully vaccinated and another 7% partially. This is almost unheard of. As we know, in the country in general and within the state of California, our Black population and other marginalized groups have had lower rates because of understandable mistrust in the vaccine. We were able to get to such a high level with a lot of, again, community outreach, education, many webinars, which were then shared. And then in addition, many presentations that were done at the JC with athletes and different groups. So again, that outreach made a big difference. Our Latinx population is at 72%. It's heartening to see that we continue to see a lot of movement in all of these groups. So hopefully we can continue to notch up a couple of percentage points in fully vaccinated. In terms of our boosters, as Dr. Mase mentioned earlier, we're at about 66% of all eligible who are boosted, and 77, almost 78% of those over the age of 50, who are the more vulnerable population. We do continue to see disparities, of course, unfortunately, between our HPI quartile 1 and 4, there's about an 11% difference. And when we look at our booster distribution with race and ethnicity, we see that we again have disparities. Our Latinx population is only 51% boosted. Our Black population and Native Hawaiian Pacific Islander at 61 to 62%. So our efforts continue to try and encourage these populations to get boosted, because we do know that the booster makes a big difference in overcoming the immune evasion that Omicron has caused. And in terms of our equity measures, you can see in the bar graph on the left, when you look at HPI quartile 1 and quartile 4, there's a 1% difference in the percent of total doses administered by HPI quartile. That gap had been significantly more, in the range of 13 to 15%. So being able to bring that down to 1% has been wonderful. Of course, these disparities shouldn't exist in the first place, but we're working hard to try and reduce those disparities. On the right-hand side, we can see the partially and fully vaccinated per percentile by quartile. So in quartile 1, 76% fully vaccinated, another 6% partially. In quartile 4, 83% and 5%. So there's a gap of about 6% between those who are at least partially vaccinated in the lowest and highest HPI quartiles that look at socioeconomic factors, access to healthcare, access to education. And again, we'll continue to try and narrow those gaps. And so the final, would you like to go ahead, Dr. Mase?
Yes, yes. And in fact, I do have a hard stop in a couple of minutes. You can stay on possibly to answer questions, but the pearls, what did we take away from all this? And this is really important. Our epidemiology team has been just amazing throughout this pandemic in providing data, because without data, we couldn't have made the decisions that we made. So we have really focused on evidence-based, data-driven decision-making. Data has informed everything we've done in this pandemic, whether it's testing or vaccines, our policy decisions, the health officer orders, the outreach, the, where to target. We have geospatial mapping showing by zip code, by catchment area, who's been hardest hit, vaccination status. Schools in these areas have been targeted specifically with pop-up vaccination sites, and just providing services for the hardest hit groups, because that's really who we in public health serve. Constant pivoting has allowed us to just nimbly respond to the different needs and stages. Constantly, as we found something new, about the virus, about transmission, as we got new variants, as we had our surges, we've had to really change what we do over time. The Health Equity Group has been invaluable in informing and help in working with us to make these decisions. We have our communications team has also been invaluable, whether it's working with the state, the Bay Area health officers, Sonoma County Office of Education, the fire law EMS groups, the healthcare workers, hospital-based, all healthcare entities, hospital-based system, FQHCs, etc. It's really the collaboration with all these different groups. SRJC, for example, with Frank Chong, having ongoing weekly calls and strategizing with these different partners has just really allowed us to achieve our goals over time. And then we've already talked about trusted messengers, and there has to be a huge shout out in reducing disparities to our CBOs, our community health workers, promotoras, all of the outreach that we've performed through our partners in reaching the hardest hit groups and providing services and information, and combating misinformation, through social media as well. All of the different media, press conferences, all the different things that we've done have been to really provide people with the best information. Early on, I think through KCSB, I don't remember the name of the radio station right off, but weekly we had town halls, through our senators and different elected officials have been involved, the board of supervisors, etc. We've taken input from community groups to identify gaps, areas for improvement, reaching different community sectors. And we have a very low unvaccinated rate as a result of all this, 11% compared to California's rate, which is 15%. And we've done better than expected, thanks to all of the different partners who have been there to provide services and make sure that people have information, and that we, again, have data-driven decision-making. So we're going to continue to move forward, continue to outreach to the hardest hit groups. We're going to continue our community outreach and education through our CHWs and promotoras. And we will continue our vaccination efforts, continue to provide testing to the hardest hit communities, and education. And we'll see where we go with COVID over time, because we don't know. We can't predict. That's been the hardest part of this pandemic, is the inability that we don't have a crystal ball and we can't predict what will happen. But we're hoping that we're reaching a place where we're living with COVID and moving forward and averting the worst outcomes. Did you want to mention anything else, Dr. Shende? I do need to run to my conference.
Yeah, nothing else to add. Thank you all for having us today. I know there may be a couple of questions. I'm happy to stay on if people want to stay on.
I'm sharing a morning thing at 8:30 here, so I'm going to run. But
thanks, Dr. Mase.
And I just would like to give a big shout out to Dr. Mase. We could not have done this without all of the efforts of Dr. Mase and her steadfast leadership and making difficult decisions that we know were best for our community. Thank you for all you've done.
Thank you, Dr. Mase.
Oh, everybody, thank you so much. I just appreciate every one of you. And it took a village for sure. And I appreciate everybody and hope that we can move forward, and that we don't have any more surges, but who knows? We're in one now, but we'll get through all this together. Thank you, everybody.
Thanks, Dr. Mase. Dr. Shende, there are definitely many people are running off to clinical duties, but can I ask a couple of the questions that are lingering? And this may have been more suited for Dr. Mase, but Dr. Jenny Fish asks, considering the current surge and the safety net issues, and still the disproportionate impact on our vulnerable populations, what makes the Bay Area public health officers not reinstate a temporary mask mandate?
Yeah, good question. At this point, what they are looking at is the impacts, of course, on the hospitalizations, which we know unfortunately lag a couple of weeks behind the surge, but what the impacts are not only in hospitalizations and death, but also on the impact on the workforce. And there are some formulas that the ABAHO group and CDPH are looking at. There's actually a meeting today. It'll be interesting to see week to week what their decisions are. But if we do get to that point where it's clearly impacting the ability to provide patient care and seeing that the mortality is increasing, that's the point where statewide and ABAHO-wide, we might look into putting in some different health measures to try and mitigate.
And ABAHO is the Bay Area, that's the Bay Area.
Association of Bay Area Health Officers, yeah.
Mm-hmm. Dr. Schneider writes, what is the local or national effort to estimate unreported cases, since we know that many of us on this call are using antigen testing rather than testing sites to be tested?
Yeah, that's a nationwide problem. It's a good problem to have because people have more access to testing, which is important. But that being said, we know that nationwide the case rates are much higher. And again, I think we're at the point in the pandemic where looking at the serious outcomes is going to be more beneficial. Wastewater surveillance, as you mentioned early on in the presentation, is going to be helpful for us because that will allow us to see if there are differences in the surge. But now that we've got rapid tests, what the hope is that people will take personal responsibility, test early, test before going out to any kind of an event, and abiding by the recommendations for isolation and quarantine.
Great. And then a question from Dr. Sherry Green about the current large outbreaks in children, and how long after a COVID infection do you recommend that a child be vaccinated?
Yeah, so the recommendations are the same for children and adults. So once one is medically cleared from an infection, which is typically about 10 days after either the first day of symptoms or the first day of the test, anytime after that should be a time when one can get vaccinated, as long as, of course, fevers are gone for 24 hours and one is clinically improving. So certainly within a couple of weeks, 10 to 14 days after the infection should be fine.
Thanks. And I have one final question, and then I'll let everyone go, which is this came up the other night when we were in clinic discussing the second booster, right? So currently recommended for everyone 50 and over. But I think Dr. Mase even said, we haven't pushed it. We're not really quite sure where we are. And one of my resident learners said, I don't know. I haven't seen convincing enough evidence for me to spend the time in a busy clinic day to have these conversations, because these conversations can be long. So do you have a quick way to think about that second booster for our people over 50 or over 65?
I think anybody over the age of 60 to 65 should get that second booster. And that's because the data really bears it out from Israel, that it did make a difference in reducing those serious outcomes, the hospitalizations and mortality. For the 50 to 65 who are otherwise healthy, it probably gives very marginal benefit. But for that elderly population, we know that the boosters do wane. We know that giving a second booster will really improve that immune response. So I would strongly focus on and recommend for that group. The other group, of course, are those who are immune compromised over the age of 12. But that should be a discussion with their primary care or their specialist. But yes, I think really encouraging for the elderly will make a big difference in reducing hospitalizations and mortality.
Great, thank you for that. All right, we have some thank yous from Brittany English about highlighting our achievements and celebrating some of our successes. I think many of us who've been on the front line, sometimes it's hard to stop and celebrate the successes. So thank you for that. And thanks again to all the community-based organizations and community health workers and promotores who have done that really frontline work. And then a thanks from Sean Ralston for assembling the COVID-19 boosters and locations and vaccination. So thank you for your hard work. Thanks everyone for your hard work. I like Dr. Mase's statement. I hope we don't have any more surges, though we're in one right now. That feels very fitting for where COVID-19 has been with us over the last two years. So thank you for taking the time to speak with us this morning. Thanks everyone for being here.
Thank you, everybody.
Join us next week for a senior resident presentation. We'll see you next week. Take care, everyone.
Take care.
Happy Wednesday.